Colleagues, welcome to the Global Coalition to Address Synthetic Drug Threats Subworking Group 3.3, February 28th, 2024, East Group session. I have a few administrative announcements to get us started. First, on how we are engaging the private sector. Over the coming months, the coalition will foster private sector partnerships at the national, regional, and international levels, targeting 6 different industries: chemical, shipping, consignment, social media, e-commerce, and banking. In a future year, we will also be looking at the pharmaceutical industry and artificial intelligence. In terms of our engagement plan for the private sector, we are first asking governments to establish national dialogues with their private sector companies. Secondly, we are looking at specialized working groups for establishment. The United States, on February 9th, established with social media companies an alliance to prevent drug harms. We brought together Snap, Meta, and Discord to discuss how best to protect youth that can access drugs through social media platforms. Next, we are looking at INCB hosting a Tech Against Trafficking forum on the 5th through 8th of March in Vienna. Then we are also looking for private sector companies to provide us with input through an exchange of experiences, through recommendations, and through achievements that we can post on our website. We will also be looking, based on the discretion of the co-chairs, for private sector companies to participate in some of the subworking group sessions moving forward from April onward. Now I want to discuss recommendations and the March meetings. Today, we are having our final meeting of the second phase of the coalition on sharing best practices and models. We have received several requests for additional presentations from many governments, and we'll be speaking to the co-chairs tomorrow, actually, to determine how best to incorporate these comments and these presentations in future sessions. Now, the co-chairs have also received a draft list of recommendations. This was also shared with all of the participants by email. So please take a look at that, because next week, March 6th and 7th, the recommendations are going to be discussed and finalized and then posted on our website. So you're encouraged to share those recommendations within your governments, and you can email us in advance of the meeting, or you can come to the meeting with comments and ideas. Now, governments are not required to implement all of the recommendations that we have, although we hope that you do. The recommendations are also not meant to serve as an exhaustive list, because you may have additional recommendations that you can implement in the spirit of the coalition. If you're not able to submit your recommendations in time for the meeting next week, that's okay. You can continue to post recommendations on the website using the interactive feature that we discussed at the last session. Now I want to explain how we move from recommendations to initiatives to achievements and outcomes. We have high-level recommendations that are very broad in nature. We have specific initiatives that were designed by international organization partners. We have over 120 of them. And then from there, we have concrete achievements, which are deliverables or kind of immediate sort of achievements that we will see over the next several months, but they will be building up toward longer-term outcomes that will make measurable progress in succeeding with the recommendations. Here's an example. One recommendation might be adopting a new innovative technique in how we collect drug data. And so the initiatives to support that recommendation could be the adoption of the Web App Assist screening tool, which is now digitized and can give us very granular information and provide that right up to policymakers, and wastewater analysis, which is also sort of very popular these days. The achievement in implementing these initiatives would be that 10 countries are now using the online assist to conduct assessments, and that wastewater analysis, you have 8 countries that are receiving training and mentoring in wastewater analysis techniques. And the longer term outcome would be that because of these achievements, because of these initiatives, now there are new drug use trends that are detected. And also policymakers are able to make decisions that's informed by the data that has been received. So I want to highlight that on our website, we have an initiatives section, and you will see that of the 120, we have about half of them that are up now, and every day we are adding more initiatives to the website. So please check in regularly over these weeks and months. And if you choose an initiative, you'll see a description, background, most importantly at the end, the point of contact of who you should email so that you can register your interest in participating in these initiatives, in these projects. So please do that. And please know also that just by registering, it's an expression of interest. It's not a commitment, because we need to sort of see what all of the demand is from all of the projects. And then we need to speak with our international organization partners, with other donor countries, and see how best we can organize and resource and support this based on the demand that we receive. But we definitely want you to email our international organization colleagues and register your interest in as many of the initiatives as you find feasible for your country. So I'm going to stop sharing my screen, and thank you very much for your attention. And now I'm going to turn it over to our friends and co-chair, Daulet Piesov and Prosecutor Aris Manguera, who are both online. Thank you both.
Здравствуйте, уважаемые участники сегодняшнего заседания.
Hello, dear participants of today's meeting. Thank you so much, Brian, for the interesting information. We all see the potential for continuing our fight against synthetic drugs. Each country has an opportunity to choose the initiatives that would be very good for the particular country, and then just take this journey from a recommendation to an outcome. Today, we are going to listen to 3 very interesting presentations. Then we are going to have time for a discussion, and you can ask them live or put them in the chat. And now, to save time, I would like to introduce our presenters. The first presentation is Mr. Sangvorn Sombatmai. He is a senior master trainer of Thailand International Technology Transfer at Chiang Mai University. Please, the floor is yours.
Good morning, everyone from Chiang Mai. Could you hear me? Okay.
Yes, please go ahead.
Okay. I'm going to present the thing that we have done in Chiang Mai here, and that one is another initiative from the UNODC with the WHO, which developed the curriculum about the family fitness developed by UNODC. I think Karen, are you here? You could add some information about the treated family curriculum. I could share my, probably I will share my screen. Okay. I think on behalf of the Thailand International Technology Transfer Center, Chiang Mai University, Dr. Apinan is the director. Today he's very busy. No.
My apologies. I'm very sorry for interrupting. You may want to bring your PowerPoint presentation into the slideshow mode. You need to click slideshow and then from beginning.
Okay. Can you see the slide?
We can see the slides, but we also see thumbnails on the left. So it's going to be a better experience for the viewers if you're able to do it, please, if you don't mind. If it's not possible, we will just view them the way it is. Thank you very much.
Okay, that's the treated family has been developed. Okay. By UNODC as a sign-informed training package on elements of family therapy intended to support practitioners in the health, social, and criminal justice sector who work with the youth and their family, especially the youth who get involved, trouble in the justice system. The package of the family treatment is where we will apply it into resource limited setting. So it's become the family treated family is in the public domain. That means that we can, utilize in our society as well. And the curriculum and the package of the development of the initiative is focused on skill development. It's common element approach. So you could see there are the package of the treated family. We have 3 packages of the curriculum. This one is practitioner manual. Other one is the study protocol, and the other one is a training manual. So we actually, after this is the background of the treated family feasibility study in Indonesia in 2019 and 2020. So they study. I think the partners of this tertiary is Atma Jaya Indonesian Catholic University, University of Indonesia, BNN, University of Hampton. So after the study being operated in Indonesia, and then we, have produced those kind of package of training. Adolescents, the study is focused on adolescents who participate in show a significant reduction in substance use and substance use related problems like fight, women, money problem, and being arrested, and in the mental health problem also. So this is how they study in Indonesia. So if you are interested, then we have QR code here. So from the beginning, what I get involved in this treated family is that, I attended the first time UNODC family treatment package for the youth with drug use disorder training in Jakarta, and on 2018. And then we have another training in Bangkok as a refresher training. And again in 2021, I attended a virtual refresher course training because during those times it's between the pandemic of COVID-19, we cannot, on-site training. And in 2021, we implement a project in northern Thailand. We divided into 3 phases. First one is to promote and conduct on-site training. And the phase 2, we did a pilot program among psychologists, nurses, from relevant justice and health agency in northern Thailand. And their phase 3, we monitoring and evaluation. This is the picture that the first training in Indonesia. During those time, I think the development, the researcher, and also working hard too. And 2019, we trained on site again in Bangkok. The participants from the almost of the Southeast Asian countries like Indonesia. No, in Bangkok, I think there were no Indonesian. They're from Malaysia, from Vietnam, from Cambodia, from Laos, Thai, and Myanmar, and those times. The training is, running as the active participation, method. This is a small group divided for a working group. So we will have more the homework before we getting into the training, the session. So almost that the thing that the curriculum will be model for elements of family therapy for adolescent substance use disorder. This one has been translated into Thai language already, and then we use this curriculum to train our participants in the northern of Thailand. So the first one, as I mentioned, that we promote and conduct on-site training divided in 2 days workshop during the May 2022. We have 25 participants from 8 upper northern Thailand provinces, like psychologists, nurses, and other counselors in juvenile courts, and 5 master trainer from previous UNFT trainer workshop, and 1 PhD psychologist from Chiang Mai Drug Treatment Center. We include those people who have potential to be a trainer, and we discuss with the curriculum, and we ask them to help us in to be a trainer also. In 2021, the first one, we already training. So the almost of the content of the UNFT is that we first introduced the UNFT to the participant. That is including systemic thinking, cultural context, theoretical foundation, core assumption, importance of adolescent in transition, and basic addiction knowledge and research evidence. Family therapy called strategy, which is we focus on positive reframing, positive relational reframing, perspective taking, and relational questions, rolling with resistance. This is the core concept and the content of the training. So 5 phases of treatment family therapy, that's been the process of the family therapy, is that we train them to, how to run the process, started with engagement, family assessment, create motivation and change, primary family treatment, intervention, termination, additional issue, and problem solving. What to do when problems all crises come up, and implements plans for recruiting new cases, sharing and discussion. And 23 and 16 participants proved feedback to the first and second training. Most were satisfied with the topic, trainers, training process, as well as the usefulness of their family counseling works. Most of them were willing to persuade their colleagues to join the future UNFT training. A series online follow-up support we did during June to August 2022, sharing case studies and supervisions. 14 cases were shared by trained participants from juvenile and family courts and civil society group. Trainers provided discussion, comment, and suggestion. This is some of the picture that we train on site. So lesson learned, translation challenges due to the difference in cultural and language context. Not all participants were able to implement their new knowledge and skill. The busy working condition, geographical and timing difficulties in arranging frequent visits their clients and family. Authorities did not understand and allow them to arrange for counseling session and follow-up. I think this condition is due to pandemic of COVID-19 during those times. Most trainees arranged a counseling session beyond the office hour. There were no policy agreement on this pilot program from the organization. This slowed down and in the implementation. So recommendations need officially participation from policy level and relevant agency. Tangible results from pilot program would be used to convince relevant authorities on the scale of plan. A proper pilot project of the officially installed the UNFT program into existing system program will need an intensive technical support with proper evaluation. Okay, thank you. UNODC, Vietnam Bangkok Office of Narcotic Control Board, ONCB Thailand, Chiang Mai Thanyalak Hospital. Okay, and Raja Nakarin Institute of Child Development, Chiang Mai. All those, they cooperate in our pilot project. Thank you. So my presentation will be finished. Thank you.
Спасибо большое, господин Sangvorn Sombatmai.
Thank you very much, Mr. Sombatmai. It was a very interesting and very useful information about family therapy. It was very interesting to learn about the challenges and the lessons learned during the implementation of this pilot project. Each country is very specific. It has its geographic specifics. It has certain challenges with translation or interpretation of the materials. And of course, your recommendations are very valuable. Specifically, it is very important that the governmental organization representatives would be interested in this work and participating actively in supporting it. Each pilot project requires understanding of the governments of the country, and of course the technical support is also the key. When we talk about non-governmental organization, of course we know how important the technical support is. It gives us opportunity to have success in our work. Our next presenter is Elisa Rubini. She is the lead expert institutional strengthening unit. Please, Elisa, and that's the floor is yours.
У нас, по-моему, запись презентации будет.
I think we have a recording for this presentation, if I'm...
Greetings to you all. It's a pleasure to be with you today and to present an introduction on case care management. My name is Elisa Rubini. I'm the CCM lead expert at the CICAD OAS, and I would like to start our presentation today walking through the essence of case care management. You might be familiar with the name, you might not know exactly what it entails. CCM is an initiative and a curriculum that has been developed by the Executive Secretary of the Inter-American Drug Abuse Control Commission, CICAD, of the Organization of American States, OAS. And in a nutshell, it wants to support a multi-sectorial cooperation and institutional strengthening of the justice, health, and social services that are connected to support opportunity for justice-involved individuals with substance use disorder to have access to treatment and social integration along the justice continuum. The CCM model entails training and technical assistance, supporting the design and implementation of pilot project. Let's have a look at where we start when contemplating case care management. Normally, countries, they do have institutions in place that have resources and have opportunities, but oftentimes these efforts are not coordinated. So there is a fragmentation of the resources available that oftentimes limits the capacity to respond to the needs of the population they serve. So how can case care management help in creating this collaboration, bringing all the actors together so there is this dialogue, communication, and synergies among all the system? Why is that particularly important? Because we see that there are different actors according to the countries and their legislation and their system in place. They might have different names, but here in the slide you see the core representation of the stakeholder. You have the justice system, you have the participant in the program, health services, social recovery support services, and community. They all are equally important. They bring a lot to the table, and they have different needs and opportunity, and some might also overlap. For example, let's have a look at the justice system. What is the Justice Authority main priority? Helping people so they don't get back and circulate to the criminal justice system again and again. So they want to stop people reoffending and support their social integration. How they want to do that? Having people complying with the expectation that might be the sanction or the expected results of the alternative to carceration program. What do the health service want? They want to be providing the best, the evidence-based treatment that are articulated according to the individual needs, and they are supporting them in their pathway towards recovery. What are the priority for the social and recovery support services? Continuing and liaising with health services so that they can further provide a layer of support and answer to additional needs that are not just treatment, but they are equally important so that the individuals are supported and guided and accompanied through their recovery and social integration. What about the community? Community is a word that encompasses everybody. It encompasses family, partners, kids, friends, and community at large. All of these are important actors that can play a role in case management in providing connections for the benefit of the individuals. I want also to spend a little bit of time to think about the participants, because this working group 3.3 is addressing population in contact with the justice system. So these are exactly our participants, are the people that we seek to help, and they have complex need and they face difficulties oftentimes in prioritizing. So since they are in the justice system, they have legal charges or conviction, and they are probably now in the alternative to incarceration program. They have health issues and oftentimes correlated mental health that have been probably neglected or not fully attended. They have a substance use disorder, a different level of intensity, but they also have other needs like and vulnerability, like lack of economic opportunities. They face a different spectrum of poverty, limited education. They have challenges in finding employment or lacking employment for long times, and they for certain face stigma. As a result, they might feel alone and confused. So they are dearly in need of some guidance and support to help them prioritizing their needs and also finding out their strength. I want to underline that no individuals is 100% deficit. They have also potential, and thanks to case care management, they might be able to explore also their full potential in more depth. So you might wonder how case care management function in reality, what is that the model entails. In these slides, you find all the core function that belongs to the model, starting with screening and assessment. Screening is just a preliminary step to understand whether there is a problem of substance use disorder and whether further attention is needed on this particular aspect, which leads to the full spectrum assessment, which is not just getting deeper in the assessment of substance use disorder, but also in all the other variables that we've seen in the previous slides. So all the aspect of the life of the participant that needs further attention and care. That leads to a more complex understanding of the needs and opportunity, which are taken into consideration into the planning. The planning is not just checking boxes and seeing what can be done, but engaging in a real conversation with the participants, with having full consent, exploring opportunities, challenges, and needs. So this planning materializes out of this discussion. The planning is not set in stone, it's not cast in stone, but it leads to an important plan for treatment and services that will be provided as inside the case care management. That leads also to the linkages with these resources that have been identified so that the participant is guided through the process of applying and brought to the services he needs, and is not left alone there, but there is an ongoing monitor in the terms of follow-up so that the individual will get also assistance while he continues and progress along with these services. There is the engagement and advocacy, which is a cross-cutting issue and is constantly related to the follow-up, because the case care manager is able to dialogue with all the people involved, all with stakeholders involved, and is actually supporting in identifying whether there are progression, whether there are setbacks, there are challenges, and if any modification needs to be applied at a certain point during the program, which leads also to the point of the evaluation, and as an important element and is embedded in the model, so that there is a discussion when designing the model on which kind of results the models wants to achieve, the system wants to achieve, and which kind of indicators, so that these data are collected along the program and will be available for the final evaluation. And then the participants will reach, hopefully, a full successful completion of the program, which is based on the expectation, which are tailored on the baseline when we started, and what the person is committed to achieve, achieving his own progress goal and the goal of the project. I want also to mention that the case care management model can be implemented at different interception points during the justice continuum. Although many countries are interested in applying that in the re-entry phase connected to probation or parole, there are opportunities to implement this function and the model during during the sentencing and post-sentencing phase. So the model is very receptive to be utilized in all these intersection points according to member states' interests and needs. Finally, I want to share some results to date that highlight our work at CICAD, specifically in the Americas. We prepared and published the curriculum, the CCM curriculum for adults in English and Spanish, and is available on our website in full extent to be consulted. We also promoted the pilot training in Trinidad and Tobago, which is the only countries so far that have gone through all the program from the training to the technical assistant launch and completed the 2 years program, having successfully supported the graduation of their participants. Training has been also offered to Trinidad and Tobago, Jamaica, Costa Rica to date, and new countries that are soon to be received the training are Colombia and the Dominican Republic. And we also have a CCM training for adolescents, which is under development. I just want to mention that since CICAD is working primarily on the Americas, thanks to the collaboration with colleagues from UNODC and ICATI, the case care management curriculum has been presented in sensitization and training session also in other countries, specifically in Kenya, in Africa, and for Asia in the Philippines. So I want to conclude that we all stand united thanks to the support of INL to provide member states with the knowledge and the technical assistance they need to explore, design, and implement case care management program along the justice continuum. Thank you very much.
Большое спасибо, Элиза, за интересное сообщение.
Thank you very much for your interesting presentation. This is a program CCM. It's very effective, and the scales you work at, it's proof its effectiveness, and the key parts of these moments, cooperation between different agents, between health agencies, law enforcement, social protection, as you said, and affordability of those this support to people who had a problem with laws and who take drugs, family problems, and relations with community also very important. And I think that in the future, when you start introduce this program in other countries and regions, it will give many results. The next word I would like to give to Professor Michael Carlo and Donald Weatherburn. They represent National Center Research of Alcohol and Drugs from Australia. The floor is yours.
Okay. You can hear me?
We can hear you. We can see the
much.
presentation. Please go ahead.
Thanks very much. My name is Professor Michael Farrel. I'm the director of the National Drug and Alcohol Research Centre at the University of New South Wales here in Australia. And I'm presenting work done in collaboration with Don Weatherburn, who also works in NDARC, who's a criminologist. And this is work done jointly between the Ministry of Health and the Ministry of Justice across many years. Next slide, please. Just scroll that down a few more things. So there's 3 things I'm going to present briefly on in the short time available. One is to talk about an evaluation of the drug court program. 2 is to talk about evaluation of a more mainstream court program. And 3 is to talk about the links in terms of pharmacotherapy between the health and the criminal justice system. And in the first one, if we just notice, drug courts have come out of the United States, and there's been one in operation in Australia now for nearly 2 decades. And one of the issues in comparing drug courts to other courts is the capacity to have widespread involvement in drug courts is a bit difficult because of the cost and scale. But what we have done here is we've compared a number of offenders who've been through the court, and we've matched them to people who are eligible for the court, but for complicated reasons didn't go through it. And we've compared them and looked at the outcomes. Next slide, please. Next slide. So basically, we've compared them on some critical things. First of all, looking at the time to first property offence after the intervention process. And what you can see here is a dotted line and a straight line, one for the control group and one for the treatment group. And what you can see here is that there wasn't an effect for that. Next slide, please. But if we look at time to first drug offence, you see there is a bit of a difference between the treatment and control group, with the treatment group looking like it's had some effect, but again, regrettably, that effect is not significant. Next slide, please. But then if we look at the cumulative thing around the first offence against a person over this period of time, and we actually do see a significant effect where the treatment group are significantly performing better than the control group. If we look at it in a different way, next slide, please. So if we then look at it in terms of mainly the treatment status and prior convictions, in particular prior convictions, what you see in this, if you look, you've got a control group in red and a drug court group in green. And what you see that for the people with less than 10 prior convictions, you see a significant difference in the offending rates per 1,000 days. But once you get to the more than 10 prior convictions, you lose that effect, and that is the same as the convictions accumulate. Next slide, please. And separately, if we looked at treatment status by gender, here we look at the offending rate. And if you look at the females, where you can see the treatment and the control group, if you look at the confidence interval bars there, they are overlapping, which indicates that there really is no significant effect for the females. But by contrast, if you look at the males, you see there is a significant effect in offending rates. Now, what explanation we have for that, we can discuss at some other stage. Next slide, please. So then the next thing really is looking at magistrates' referral into treatment. And this is basically where we're using the main court system, and it's referring people, instead of going to court, referring them to community treatment. And that type of treatment is the broad range of community treatments available, which is psychosocial treatment, cognitive behavioral treatments, counseling, and pharmacotherapy where appropriate for a range of different substances. So next slide, please. So this is a classic way in which to look at a much broader range of people, and it really captures the broader community. And the idea really here is to be able to get these type of people, and what we wanted to do, next slide please, is we had 10,000 people who'd been through this process, and we managed to compare nearly 10,000 with people who were not referred but matched and were pretty similar along a range of parameters here. And I won't go into them, but to look at really the outcomes of basically reoffending, imprisonment, and death. Next slide, please. And when you look at that, what you see in the treatment group versus the control group, looking at a Kaplan-Meier survival plot, you see a significant better outcome for the treatment group than the control group across the period of time. Next slide, please. And if we look at that in relation to imprisonment rates, we see that the treatment group are significantly less likely to be imprisoned compared to the control group. And if we look at mortality, the treatment group also is significantly less likely to die than the control group. Next slide, please. So then, next slide, please. So then looking abroad at the opioid substitution programs across Australia, here we see that we've seen the development, we see that we have about 50,000 upwards people on opioid substitution treatment, and we see that about half are on methadone and half on buprenorphine. But in the last few years, half of those on buprenorphine are on long-acting injectable buprenorphine, mainly receiving it monthly. Next slide, please. And in this, if you see in the lower part of that slide, you can see the blue line there, which indicates the growth in long-acting injectable buprenorphine in the prison system. So we've seen a substantial expansion of this new type of treatment in the prison system and linking back into the community. So last slide, please. So then if we look at a separate linkage program we've done looking at the impact of opiate agonist treatment on people who are both in prison and after release. And this is a cohort over 15 years with about 25,000 participants. And we see that the hazard of death within prison for those on treatment compared to those on not treatment is reduced by 74%. And if we look at in terms of release, we know that people on release who are opiate dependent have a 70-fold increased risk of death in the first 4 weeks. And what we see here is the treatment is associated with a 75% reduction in that. And separately, we modeled this to show that when we have a comprehensive program across the community and the criminal justice system, that we can reduce overall reduction of 40% in overall mortality for affected individuals. Last slide, please. So this is my email. If people have questions, I have publications on these, but to summarize what I've described is I've described modest effects for both the court system, for the criminal justice, the merit system of referral, and slightly stronger effects for the OAT prescription system. But overall, all of these systems work together, accumulate, and demonstrate significant impact. And I haven't presented data on cost effectiveness in that because it was not an experimental study, but it is an area for consideration. Thank you very much.
Большое спасибо, профессор Farrel. Очень
Thank you very much, Professor Farrel. These are some very interesting results, and they really prove the effectiveness of these measures. And I think your research requires additional studies. So thank you very much for providing us with your presentation. We are going to be able to study the slide and look at them in more detail. We don't have very much time left, so let us be brief. And now I would like to give floor to a representative from the Philippines, Maria Regina Hechanova Alampay, ICAP 2, Chief of Party. Please, Maria Regina.
Hi, everyone, and thank you for the opportunity to share. First, I'd like to thank all the those who shared, so from case management to actually looking at the impact of evaluation, to the interventions.
Maria Regina, my sincerest apologies. I'm very sorry. Could you speak a little bit close to your computer? It's a little bit distant. Thank you.
All right. Is this better?
That's better. Please go ahead.
Right. So I was asked to share a little bit about the kind of work that we're doing for, in terms of incarceration for people who are court mandated in the Philippines. And I just wanted to share very briefly about the program that we did, which is actually an offshoot of the DC materials. So we have in the country what we call plea bargainers. So these are people who are incarcerated because of drug use, but are released earlier because of to address congestion. We did a profile and we found that obviously mostly were males. Most were really low-level drug users and low level of education. We compare them to another batch of clients who were voluntary, those who were who voluntarily but were not incarcerated received treatment. And we found that those who had court mandated had higher substance use, more drug use, less recovery skills. Because of this, we actually developed a program that is now being used in our Bureau of Jail Management and Penology, as well as some of our local government units. Just wanted to acknowledge DC because they provided the base materials for what became a three-part program featuring drug recovery skills, life skills, and family modules. So these are run by paraprofessionals, both in communities and in prison. I just wanted to share also that we did evaluate the program, and our randomized control trial actually showed, so we did 3 groups, one no treatment, one in community, and one in jail, which is pre-release. And we actually found that compared to the no treatment, those who received it either in the community or in prison actually reported better recovery skills, better life skills, and there was no difference whether they are in prison or not. So I just also wanted to share that this has been adopted by our Bureau of Jail Management and Penology, and many of our LGU, local government unit partners, including Makati is here today, have already adopted it. Our main problem is that it has not yet been institutionalized across the country, so there are still a lot of sort of cracks. When prisoners come out, there's no local government unit to provide them this kind of support. So they do end up sometimes back in jail because there's no kind of sort of treatment that they actually did receive. But right now, the silver lining is we are beginning to roll out programs across all the jail facilities. So hopefully they do get some kind of treatment prior to their release. So thank you for allowing me to share this, this initiative in the country.
Большое спасибо, Мария.
Thank you very much, Maria. That's some interesting information. And now I'd like to give floor to my co-chair, Aris Manguera. Please, Aris.
Hi, good morning, everyone. So we're formally opening the floor for questions. Do we have any questions? Yes, Terrence?